Okay, so today we're going to talk about neonatal dermatology and external visual clues to making diagnoses in the newborn. I have absolutely nothing to declare for this talk, and what we want to do is recognize what's normal and abnormal in external signs in the newborn and what that means, and if we need to do any treatment or testing, or if it's perfectly normal and we can be very reassuring. Now, as Dr. Bunch said, she's going to be taking the chat questions and throwing them out to me. If that's easier for you to do, to ask me a question, please ask me a question at any time. Or if you want to turn your voice on and ask me, that's okay too. But you really have to participate mentally in this talk because I'm going to be showing you pictures and you have to think of what you're seeing and kind of tell yourself what you're seeing or tell us what you're seeing, and then think of what it is that you're seeing, okay? So here's our first one, and I hope the screen shows up okay for most people. So what do people see here?
Looks like some small vesicles or pustules with surrounding erythema.
Very good. An absolutely perfect way of doing it. So what is this?
Neonatal acne?
Hard to have acne on that part of the body, I think. You know, but you can.
Neonatorum
but, you know,
TOXICUM.
Yeah. So it's got this awful name, right? And if you tell this to a parent, they think the kid has some awful disease. So don't tell them what the name is. Erythema toxicum neonatorum. Because this is completely benign, self-limiting. These erythematous areas with these papules and pustules in them can be anywhere on the body except the palms and the soles. And you can have just a couple of them or you can have several hundred of them. But they're completely benign. And we have no idea why some babies have it and some babies don't. Now, they usually start as this blotchy erythema that's completely macular. And then they develop these little pustules or papules, which are white or yellow in it. And the redness areas is very irregular and splotchy and can be anywhere from a few millimeters to several centimeters in diameter. And because it's so irregular looking, it's frequently called flea-bitten in the literature. We usually see erythema toxicum in the first 3 to 4 days of life, but you can see it immediately after birth, and it can occur as late as day 10 of age. And in the first couple of weeks, this rash will come and go. It'll move around and come and go. Very, very rare to see it in premature babies. It's usually the term babies we see it in. If you look at the histology here, if you do Guim system, you'll see eosinophils around the pilosebaceous area in the dermal epidermal junction. There will be no bacteria if you did a Gram stain, except you'll see these clusters of eosinophils. So that's erythema toxicum. It's going to go away. We don't have to do anything except say it's fine, it's normal. Okay, so what do we see here?
Congenital dermal melanocytosis.
Okay, so we're seeing a dark spot in there, and it's sometimes called the Mongolian spot. It's flat. It's usually this blue-black color, but it could be gray or deep brown. They're usually large. They're usually over the gluteal and sacral areas, but they can be on other areas of the trunk or limbs. Much more common in Orientals than Blacks and American Indians, than Ladinos, less common in whites, less than 10% in whites. This is present already at birth. It will fade somewhat in the first year or two of life, and it's usually completely disappeared by the time the kid is 6 to 10 years of age. However, a very small percentage of adults will still have this spot into adulthood. Mongolian spots can be single or multiple. They can be a few millimeters up to even 10 millimeters. And histologically, they're spindle-shaped melanocytes that are deep in the dermis. Incidentally, if you have a very large Mongolian spot, it's always a good idea to have one of the pediatric dermatologists eventually start following this kid. Okay, so what do we see on this one?
It's like milia.
That's the diagnosis, but what do you see?
Small little papules or pustules with no surrounding erythema.
Okay, very, very tiny little papules, right? Most commonly, that milia is seen on the face. We see it in up to half of the newborns that we examine, and it is the result of retaining keratin and other sebaceous material in the pilosebaceous apparatus. So you get these tiny 1 to 2 millimeter papules, usually white or yellow, most prominent on the cheeks, the nose, the chin, and the forehead. And you can have just a few, as we see here, or you can have lots and lots of them. But they're usually in groups. Occasionally, besides being on the head, it'll be on the upper trunk or the limbs, even the mucous membranes, and even sometimes on the penis. Milia will usually disappear in the first 3 to 4 weeks, but can persist up to 3 months. If it's very persistent, if there's a very widespread distribution and the child has other defects, then you have to think of some other syndromes like hereditary trichodysplasia or oral facial digital syndrome. Now, you don't have to remember the symptoms, just that if it's widespread and persistent, you ought to think of other things. Okay, so what does one see here? You don't have to know the diagnosis, just describe it, and maybe it'll bring the diagnosis. Okay.
Looks like pustules.
Okay, could be pustules or papules, but it seems to have an inflammatory or erythematous area around it. Okay, here's another picture of it in another part of the body. Again, you're seeing these papules with this erythematous kind of inflammatory type base. And this is MILIARIA rubra, otherwise called prickly heat, which is caused by sweat being retained because of immature eccrine ducts. And we see this mostly in the first few weeks of life. So it can look papular or vesicular, sometimes macerates, and it's because these gland ducts are plugged up with keratin, and you get the redness because the sweat then escapes into the skin underlying the area of obstruction of the duct, and it causes kind of an inflammatory reaction, and that's what causes the erythema. Now this is Miliaria crystallina, which is exactly the same thing, only the sweat doesn't dissect out under the obstruction in the ducts, so you don't get the inflammation, you just get the papules all over from the sweat retention. Okay, here's one that looks a little bit similar, but isn't similar. And what do we see here?
Yeah, multiple erythematous papules without surrounding erythema or macules.
Very good. Okay, so what could this be? Nobody wants to guess here. Nope. Okay, well, this is neonatal acne, which very much can look like adolescent acne. Usually starts about 2 to 3 weeks of age. It's thought to be because of hormonal stimulation of the sebaceous glands, and you get these red papules, pustules that look inflammatory, mostly on the cheeks, but can be anywhere on the face. But the nice thing about this, as opposed to adolescents who have bad acne, is no treatment is necessary whatsoever in the newborn because this will go away on its own. And it might not look very nice for a few weeks, but it will go away. Okay, what about this?
Looks like two
Are those
pustules.
pearls?
I'm sorry, say again, please.
Are they Epstein pearls?
Okay, so what we're seeing are these white, pearly white things on the heart palate, to the center of the heart palate, and their Epstein's pearls are discrete 2 to 3 millimeter round, and they're usually either pearly white or yellowish, and they actually are mobile on the midline of the heart palate. If you see it along the gums, like you're seeing in this slide here, then it's called Bohn's pearls after the people who described them originally. If you look inside and look at the palate in most babies, you're going to see these in up to 85% of newborns. So it's very, very common if you're really looking in there, and you should be looking because you don't want to miss a posterior cleft or something else there, okay? So histologically, it's the same as milia, and this will disappear spontaneously in the first few weeks. Nothing to worry about there either. Okay, so those were easy ones. Now we get a little bit more difficult. So let's describe what we see on this one. Don't have to know the diagnosis, just have to tell me what you see, okay?
So I'm seeing some pustules with like a whitish, fluid surrounded by some areas of desquamation and a little bit of erythema.
Mm-hmm. Very good. So anybody has any idea what this is?
Is it transient pustular melanosis?
Bravo. Many brownie points. Very, very good. This is exactly what it is. It's transient neonatal pustular melanosis. And the giveaway is all these areas where you see the denuded skin here, but it's not looking like it's infected or inflamed. Whereas when you see these pustules, you're thinking, oh my God, this should look really infected type of a thing. So this is transient neonatal pustular melanosis, which is vesicular pustule, and eventually after they break, and they break very easily, the areas become hyperpigmented, and that's why it's also called a pigmented disorder of the newborns. So these lesions rupture easily, and very often at birth, they will all be ruptured, or most of them will be ruptured, and all you'll see is these little areas of denuded skin. You might see a few residual pustules. This hyperpigmented macular areas that come from the denuded areas will fade in a couple of weeks to months. So you can see transient neonatal pustular melanosis usually at birth. And you may see clusters on the forehead, the back of the neck, the chin, the lower back, the shins, occasionally other parts too, but very rare on the scalp or palms or soles, even though this picture shows it on the scalp. It is pretty rare there. So when you look at pustules, your first thing is, oh my God, I need a gram stain, I need a culture. And you do, because you want to make sure that these lesions are really sterile to reassure yourself. If you do a right stain, you will see neutrophils and cellular debris. If you do a gram stain, you will not see any microorganisms because this is not infected, okay? This is a totally benign process. These babies have no signs of being ill. They are feeding well. They have no fever. Nothing is wrong. And no treatment is needed. But what is needed is recognizing that this kid doesn't have, pustules from an infection, but that this is just a transient neonatal pustular melanosis. So occasionally you're thinking, oh my God, is this staph, is this herpes? And you have to look into that to make absolutely sure that this is a benign process and that's something that you have to do something right away about. Okay, this is interesting. Can somebody describe what they're seeing here?
Looks like multiple subcutaneous nodules with some overlying erythema.
Very good. Very good. That's exactly what it is. Okay, so what is this? This happens to be the baby's back. So you're seeing the area with the spine and the air around it on the baby's back. Okay, well, this is subcutaneous fat necrosis in the newborn. Here's another one with it on the baby's back there. Okay, and this is something that's mostly benign and self-limiting, and I put the word mostly emphasized in quotation. These lesions are very sharply circumscribed. They're nodular, as you described. They're indurated, and they're areas of fat necrosis. And this is related to trauma during delivery over bony areas, and may be increased if the baby's had asphyxia or hyperthermia or stuff like that. Now, it usually appears within a few days of birth to up to a couple of weeks of birth. It's not usually very apparent right immediately after birth, these areas. They're usually painless, but occasionally they're quite tender. And again, you see them on areas that can be traumatized when the baby's being delivered. The back, the buttocks, the arms, the thighs, the cheeks. Now, I said that they're mostly benign, but the trouble is it can develop extensive deposits of calcium. And these deposits of calcium will harden. You'll get hardened areas, and then they eventually liquefy, they drain, these areas heal, they may leave some scars, and this whole process usually resolves in 2 to 4 weeks. The trouble is that sometimes it can cause hypercalcemia. And the trouble is that we don't always know who's going to get hypercalcemia. We look at the kids who have more extensive areas and we worry about them more, but we can't always predict which kid is going to get the hypercalcemia and which kid won't. And sometimes the onset of the hypercalcemia can be delayed. And if you have kids who have extensive subcutaneous fat necrosis with calcification, you may have to monitor their calcium levels for several months because of this. Now, initial symptoms of hypercalcemia in babies are very nonspecific. They can be irritable, they don't feed well, they may have constipation, but this hypercalcemia can go on and be very serious, can cause seizures, can cause kidney failure, and can cause cardiac arrest. So it's something you really have to pay attention to if you have a child who does have subcutaneous fat necrosis. That's fairly extensive. If there is hypercalcemia in the newborn, we do restrict supplemental calcium and vitamin D. Now, that doesn't mean we restrict breast milk or formula in the baby. They have to be fed normally. It means we don't give any supplemental calcium or vitamin D. We also want to give a little extra IV fluids to hydrate them so we can flush this through the kidneys easier. And we do use sometimes furosemide, which is a calcium wasting loop diuretic. In the kids who are more severely affected, we actually go on to use systemic steroids and occasionally biphosphonates in the newborn baby with severe hypercalcemia. Okay, this one's easier. So what do we see when we look at this baby's feet? And this is a different baby and looking around the mouth.
There's a blue tint to his perioral area and to his extremities. I think his toes and his feet look a little blue.
Okay, so if you just see it on the extremities, what do we call it?
Acrocyanosis.
Acrocyanosis. Right, versus if we see it around the mouth, that is central cyanosis. And central cyanosis is always a cause for us to worry, whereas acrocyanosis is not if there is no central cyanosis. Okay, so acrocyanosis has to do with, immature blood vessels and vasospasm and secondary dilatation and pooling of blood. in venous plexuses in the hands and feet, which causes that cyanotic appearance. And it'll get worse if the baby gets cold, or if the baby cries, or if the baby holds their breath. But as soon as that passes, it gets better. So it's nothing to worry about versus the kid who has central cyanosis. Okay, here's another easy common one. Does it look like this baby's peeling? Yes. And newborns normally desquamate. We usually start to see it around 24 to 48 hours of age, and they continue to desquamate their skin. Just think they've been sitting in water for so long. What would you do if you were sitting in water so long too? You desquamate also. So this goes on throughout about the 3rd week of life. It's pretty abnormal to see desquamation right away at birth. You can see that if the baby's post-mature, or if the baby's had intrauterine hypoxia, or if there's congenital ichthyosis. But otherwise, in a normal newborn, you usually don't see desquamation starting until a day or 2 after birth. Okay, what about this one? Am I losing my audience, or?
No, we're here. So down the legs bilaterally, there's kind of a lacy appearance of the skin with maybe a little bit of hypopigmentation surrounded by some possible erythema.
Or maybe that's normal white skin with the erythema being the
Yes,
reticulated thing that's going on there. So there's this lacy appearance of redness in the skin there, right? And this is called Cutis marmorata. It's normal. It's a mottling that's usually red, but could sometimes be bluish on the trunk and extremities. And it's a physiologic response to the newborn being chilled. And this physiologic response can persist for weeks or months. But if it can persist a lot longer, or maybe not even go away, in children who have Down syndrome or trisomy 18 or the Cornelia de Lange syndrome. Remember the single eyebrow, the long eyelashes, and the mental deficiency, and all the other things that go with that one. Okay, so this looks pretty similar. Maybe a little coarser than the one before. Just to go back to this one, which is a little finer. This one may be a little coarser, but this does not resolve with warming. And this has a name that's a big mouthful. Cutis marmorata Telangiectatica congenita. It's also sometimes called nevus vascularis reticularis or congenital livedo reticularis. But what it is a vascular anomaly, okay? So you have this cutaneous vascular reticulated network that can be accentuated by cold, but it doesn't go away totally when you rewarm this child. It's still going to be there. And as I said, it is coarser looking than the one we saw before. And this may result in some skin atrophy later on, or even ulceration. Now, Cutis marmorata Telangiectatica congenita is most of the time on the limbs, especially the legs. Can be on the face and trunk, but that's much less common. And when it's on a limb, you have extra blood supply, and that can cause the limb to overgrow and to have a shape discrepancy. So you may have a limb size discrepancy, one side to the other if you only have this on one side, and a shape discrepancy. Now the cutaneous part that you see usually will fade and resolve within a couple of years, but rarely it can persist unchanged even into adulthood. This is an interesting one. Yes, please, David.
Could you go and kind of toggle between the two, the the previous Cutis Marmorata and the Telangiectatica, just so we can kind of see the difference briefly?
Sure. Again, it's pretty subtle. This is a more finer reticulated pattern. This is a little bit more coarser, okay? Now, the difference being the other one is going to go away when the baby warms up. This one is not going to go away when the baby warms up, and that'll make it much easier for you than telling how fine or coarse it is when you look at it, okay?
Okay, thank you.
You're welcome. Thank you. So this is an interesting thing to see. What do you see here? A two-tone baby, huh? This baby is half red in the back and half white in the back. And this is called, it's called HARLEQUIN color change. We usually see it in premature babies, but sometimes we see it in term babies. And it occurs when the baby's lying on their side. And you get reddening of one half of the body with blanching of the other half. So one side is red and the other side is blanching from lying on the side there. These attacks may happen suddenly. They may last for 30 seconds up to 20 minutes. And the upper half is always the paler side and the lower half is the red side. And there's usually this nice clear line of demarcation, but not always. As you can see in this baby over here, there's no clear line. There's partially clear line of demarcation, but then it gets irregular. But most of the time it's fairly clear, okay? It's related again to immaturity of the blood vessels. This reaction usually peaks at between days 2 and 5 of age, but can start within hours of birth and go up to 3 weeks of age. But it's a really peculiar thing to see when it happens, and usually will go away within a few weeks. Okay, what's this one?
Looks like a patch of erythema.
Okay, so we've got a large patch of erythema here. There's actually some erythema here and maybe a little on this eyelid too, if you really look, okay? So it's called NEVUS simplex. Sometimes it's called a macular stain or a salmon patch or an angel kiss. And if it's on the back of the neck, sometimes it's referred to as a stork bite because obviously that's where the stork brought the baby holding them there. It's a vascular malformation, and you can have single or you can have multiple. And it's blanchable. If you push on it, it will blanch, and it's pinkish to red patches. You will see nevus simplex in about 40 to 60% of your newborns. Very, very common to be on the eyelids, the upper eyelids, and on the glabella, and the midline of the nape of the neck, okay? Less commonly, you can see it on the nose, the lips, the back, or the scalp. And almost all of them will fade in the first year of life, except the ones for the back of the neck, the stork bite ones. Okay, this is a fairly easy one to describe.
There's some large erythematous patches with yellowish crusting.
Mm-hmm. And what do you think this might be?
Seborrheic dermatitis.
Seborrheic dermatitis, right. Very distinctive. That kind of greasy scaling and patchy redness can cause fissuring, especially behind the ears, and occasional weeping. And it's an inflammatory dysfunction of the sebaceous glands. We see it mostly on the scalp, the face, behind the ears, sometimes the trunk, and in areas of skin folds, mostly. Usually starts within the first 3 months of life, usually starts in the scalp where it's called cradle cap. And then it may spread over the face and affect the forehead, the eyebrows, behind the ears, the nose, the back of the head, etc. These lesions can be all over the place, though. They can be greasy. They're usually salmon colored and scaly, and it's not itchy. It's no dry skin or follicular keratosis like you see in eczema. So you may not get that family history of atopic disease because this is not atopic dermatitis. And most of these cases will clear up by themselves by 8 to 12 months of age. Okay. Well, I already showed you transient pustular melanosis in the newborn, so this can't be it, right? Unless I'm repeating myself.
You're so good, David.
So these are small, well circumscribed vesicular lesions. Looks like on the gluteal area, in various stages of formation, and yeah. Oh, I cheated. Impetigo.
Sorry, my fault. I hit the wrong thing here. Yeah, so we've got areas that are small and large kind of pustular areas and areas that are denuded, but these look much more angry than that denuded skin that we saw with the transient neonatal pustular melanosis. So impetigo in the newborns can be seen as early as the second day of life or as late as the second week of life. And it's these superficial vesicular pustule or bullous lesions, which usually, if you have light skin, have an erythematous base. And mainly we see them in areas of skin folds, the diaper area, the neck folds, the groin, etc. Now, it's fortunate that this is very rare in nurseries to see this nowadays, because this infection is devastating, okay? You certainly want to do gram staining cultures, and most of the time you're going to see staph, rarely group A strep, and these kids need antibiotics ASAP. They need to be in the NICU and watch very, very carefully because this infection can really be devastating. So what do you see on this baby? Well, we obviously see areas of denuded skin, skin that's kind of peeling off. What looks like a very, very large, maybe either denuded or bullous area, areas where skin has been, peeling off here. And this is a kid who has staphylococcal scalded skin syndrome. Again, fortunately, something that we see extremely rarely nowadays in the newborn nursery. Used to be much more common. Newborns are very, very susceptible to the exfoliative toxin that's secreted by Staph aureus. Usually scalded skin will present at 3 to 7 days of age. Very rare to see it right off the bat when the baby is first born. Extremely dangerous illness, very worrisome. You get tense bullae that are often not even intact at presentation, like you would see at in the transient neonatal pustulosis, but this is a much more extensive, horrible looking thing. Now this one could be the same thing, but it isn't. This is a collodion baby, which is an X-linked ichthyosis, which there's a collodion-like membrane on the baby at birth involving the entire body with large scales and corneal opacities, and it can be very, very bad. There's a severe form called HARLEQUIN fetus, which is fortunately very rare and is not compatible with life. These kids will not live more than a few weeks. The picture was so awful, I deleted it to spare your feelings because it really is most disturbing. Okay, here's something much more common. This is obviously the kid's belly button, and what's going on?
it looks really irritated and infected. I
Mhm.
can't see on my screen if that's a little like blood clot at the bottom of that belly button, you know, inferior to
I
it.
think you're seeing just the dry cord here, Kristen, but you're seeing that there is erythema around the umbilicus, and this is very, very worrisome, okay? It's called omphalitis. The umbilical cord, you know, as it heals, that necrotic tissue is an excellent medium for bacteria to grow in, and you can get an extensive infection. The thing you want to be careful of is sometimes something that's resting on the area can cause an irritation, most commonly the cord clamp. Okay, so the cord clamp is pushed by the diaper on the skin, and when you're examining the baby and you take the diaper off and the cord clamp moves, you see an area of erythema, and you say to yourself, you know, is this the start of omphalitis here in this kid, or is this from the cord clamp? So since the cord is usually pretty well healed, you just take the clamp off, remove it, have the mother watch it, you go back and look at it in half an hour without anything pressing on it and see if it looks better or not better to distinguish between the start of an omphalitis and just a little pressure erythema. But I've seen this very commonly with cord clamps, or sometimes even just something else pushing on the baby, but it'll go away when you take the pressure thing off, whereas the omphalitis will not go away, okay? So omphalitis is a potentially lethal infection. It's in the abdominal wall around the umbilicus, but it has the potential to go deep into the tissues, into the peritoneum, into the umbilical vessels, the portal vessels, or the liver. It can cause necrotizing fasciitis. It can cause bacteremia, sepsis, and portal hypertension or death. So it's something you really don't want to miss. You know, if you're seeing some erythema starting around the cord there, pay very particular attention to it. Okay, so this is another belly button on a newborn. This is a pretty common thing. I'm sure most of you have seen it.
Yeah. Are you?
Go ahead. You
Oh,
go.
okay. So it looks like around the umbilicus, there's it's protruding. No surrounding erythema. Potentially a little bit of you know, healing skin on the inferior portion, but that's kind of what I would think.
Okay, so you're right, it isn't quite healed, okay, and this can form what we call an umbilical granuloma. So the cord will usually dry and separate in 6 to 8 days and be completely healed by 2 weeks of age, but sometimes it doesn't epithelialize totally, and that's what you're seeing here. Oops. Is you're seeing a lack of epithelialization in this area here. And you get this kind of a granulating area, which can have a little bit of a mucoid discharge, or sometimes has a horrendous mucopurulent discharge. It looks awful, like, oh my God, this kid has some kind of horrible infection, but they really don't. It's just this leftover piece of cord is still putting out stuff there. Usually I will give the parents some alcohol pads and tell them to wipe inside the belly button a couple of times a day, and it'll dry up. And the reason I give them some alcohol pads is I don't want to tell them to put alcohol on something and do it. I have no idea how much alcohol they're going to put on this baby's skin, and alcohol will be absorbed through this very thin skin very easily. So I just give them the little alcohol pads and, you know, use it a couple of times a day. And if it doesn't get better, you know, let me know. If it persists despite being tried to be dried out with the alcohol pads, then you want to cauterize it with the silver nitrate stick. And sometimes you have to repeat that in a couple of days. And when you cauterize it, you don't want to just do the very tip of it. You want to get inside there to the base, you know, on the base of this little granuloma, but you don't want to touch the normal skin because you'll stain the skin and you can even burn the skin. So you have to be very careful when you do this to get the granuloma and get around to the base of it also to cauterize it. And it's very easy to treat. Okay, another belly button. Easy one. Okay, this is a little umbilical hernia. Yeah, go ahead.
I was
Nope.
just going to say it appears to be bulging from the belly button.
Yes, right. Very good, Kristen. Yeah. So, and if the kid's crying, it's going to be bulging a lot more. Yes. Okay. So it's an imperfect closure of the umbilical ring. There's frequently an associated diastasis recti with it, not all the time. It's more common in our Black population and our low birth weight population. And as I said before, it looks much bigger when they're crying or straining. Sometimes it can look enormous, and the parents, it's, oh my God, this thing is enormous. But when the kid calms down and they're not crying, and you put your hand gently there, and it, all the air is pushed back into the belly there and from the gut. You feel the defect, and it's really just the tip of your finger. It's really, most of the time, not a very big defect at all. Most of these will go away by a year of age, even the big ones. The nice thing about umbilical hernias is they don't incarcerate. They're not like inguinal hernias. Inguinal hernias in a newborn are an emergency because they will incarcerate, since the baby can't tell you all the time that things are not going well. So umbilical hernias, benign neglect is your best way. If it's still a big thing there by the time they're 5 years old, they can have an outpatient procedure, which is very small, to fix it. Okay. Another belly button problem.
Omphalocele?
Yep, this is an intact omphalocele, correct. Yeah, so it's a herniation of the contents of the abdomen into the umbilical cord. And in this case, we see it's covered in peritoneum, which is good because that's protecting all the abdominal contents there. I mean, hopefully you would have picked this up by ultrasound, and this kid would have been delivered in a hospital where they have, not just neonatologists, but they have pediatric surgeons who know how to deal with this kind of problem, et cetera, et cetera. But if the mother came in without prenatal care and you saw this in the delivery room, your first thing is to get some sterile lap cloths with sterile normal saline and put it over this, because you don't want this to dry. And you don't want it to get infected, okay? And then this kid needs to go someplace where there's a pediatric surgeon who can deal with this child's problem, okay? So if you are taken by surprise by a mother who had no prenatal care, sterile lap cloths, sterile saline, keep this moist, keep it clean in transport for the kid, okay? If it's possible, they will immediately correct surgery to avoid infection and tissue damage. Or if there's a rupture of the sac, also, you have even bigger problems. These things are associated with other anomalies and syndromes. You're probably familiar with Beckwith-Wiedemann, where they not only have the omphalocele, but they have large internal organs, including a large tongue, and they have hypoglycemia. It's also associated with trisomies 13 and 18. So this is what a ruptured omphalocele would look like. Again, you have to cover it and get this kid transport if this surprises you someday. You want to protect it from drying and being infected. If there is no room in the abdomen because these organs grew outside of the abdomen, so the abdomen didn't expand, so if there's no room, the surgeon can't replace it right away. So what they usually do is they sew a mesh, they sew a mesh here onto the sides, sterile mesh, and hang it. And every day they make that mesh a little smaller with some sutures until they finally expand the abdomen and they can get the abdominal contents back in there safely. Okay? Now, this one is not an omphalocele because we have an intact cord here and an intact belly button area. So what's this one?
Gastroschisis.
That's right. This is a gastroschisis, right? It's a defect of the abdominal wall. Again, you have to be careful to cover it to avoid fluid loss, drying, and infection. And again, they have to gradually expand the abdomen to get the abdominal contents into it. Okay, another part of the body.
Mastitis?
Yeah, this is mastitis, right? So even babies can have mastitis. They can even have abscesses in there. It's rare in the first week. You usually see it in the second or third week of life. The bacteria invade the ducts and get in there. It's usually staph, but we can see E. coli, Pseudomonas, Proteus, Salmonella, and even group B strep in this. Okay, so here you can see a mastitis that's more subtle than the one in the case before. Now, breast enlargement in the newborn can be a perfectly normal thing from mom's hormones, and sometimes they even have a little discharge of milk. So it's important not to miss the baby who has the mastitis or abscess from the baby who just has, enlarged breasts, which are a normal finding from the hormones and will go away with time. Okay, what do we see here?
I'll play.
Yeah, go
This
ahead.
is-
Hi, Dr. Witt.
Hi, Dr. Ann. This looks like a sucking blister to me.
Absolutely.
In a location very accessible to the baby, and they love to suck on anything they can get in their mouth.
Including intrauterine. That's right. So you're seeing denuded skin, and you're seeing these little sucking blisters here. But you can see it in lots of places that they can get their mouths to, but mostly it's the hands or the arms that they get this into. So the important thing is to recognize that this is a benign thing and not to worry about it. And here's sucking blister from sucking on bottle or mom or whatever on the lips. What about this one? Okay, so how about describing what you see here?
Well, there's an area that isn't growing hair, and it also looks like it's depigmented a little bit, maybe scar formation.
It looks funny, right? There's no hair. It doesn't look like a normal area, right? Anybody think that this is from putting in an intrauterine monitor? Good, no. Okay, this is, if you put a monitor in, this is what you might look at, like you might have a little, erythema, some old bleeding, but you'd have hair in the area. Whoops, sorry. You'd have hair in the area, okay? Whereas in these babies, there's no hair in the area, as Kristen pointed out, okay? So this is aplasia cutis congenita, which is a congenital defect. There's a local absence of epidermis, dermis, and subcutaneous tissues. And you'll see this at birth. Most of them are on the scalp, but they could be on other places in the baby too. Okay, most of them are solitary, but there could be multiple. But the thing is that they're very sharply demarcated. They can be granulating, they can be weeping. They're somewhere between 1 and 3 centimeters in diameter. And there can be associated other anomalies, cleft lip and palate, hydrocephalus, skull defects, brain, limb, eye, heart, vascular, etc. So if you see one of these areas where there's, nothing there that should be, no epidermis, no dermis, nothing there, think about looking for other congenital defects in the baby. Okay, so this is the kid's knee, looks awfully big. You see this at delivery. Kind of looks vascular. No volunteers. Okay. So this is a congenital hemangioma. Now, most of the hemangiomas we see are infantile, but this is a congenital one. This is a vascular lesion that is already fully grown and present at birth. Now, you may make a diagnosis on ultrasound if it's sufficiently large enough, prenatal ultrasound, so that you're expecting this already. But this is different from the infantile ones, which we'll talk about in a minute. This is a congenital hemangioma. Most of them are in the skin, but it can be in the liver. And these don't grow after birth, except proportionately as the child's area grows, okay? And the incidence of males and females are identical, okay? Most of the time we see congenital hemangiomas on the head, neck, or on the limbs. There are two different types of congenital hemangiomas. The first type is called the rapidly involuting one, or RICH for rapidly involuting congenital hemangioma. And this goes through a very rapid regression phase and may be completely gone by the time the kid is 12 to 18 months of age. So this is involuting from this to just a little loose stuff over here. Okay, the other type is the non-involuting congenital hemangioma, which will grow proportionately as the child grows and does not go through a regression phase. So those are much rarer. Now we'll talk about the ones that we see more commonly. And what are these? These are the infantile hemangiomas, right? Okay, and you may not see any of them at birth, or you may see tiny little red dots, a couple of them, a few, very small. But when the baby comes back for their 2-week checkup, all of a sudden they have this. Mom's concerned, okay? So these are infantile hemangiomas. And so at birth, you may see nothing, and then slowly over time, these things start to grow, okay? Infantile hemangiomas are the most common benign tumor of childhood. It's an abnormal proliferation of endothelial cells and blood vessels, and it's clinically and histologically different from the congenital hemangiomas that I mentioned a minute ago, and much, much more common, okay? You will see infantile hemangiomas in up to 5% of infants. It's more common in females and in whites, more common in preterms or low birth weight twins, and a whole bunch of other things that it's more common in. You usually see it start before 4 weeks of age. Again, you might see little tiny things at birth, or you might not see anything for a few days or a few weeks, and it can appear about by 4 weeks of age. And then it will have a rapid growth phase between 1 and 3 months of age, with an accelerated rapid growth phase between 5 to 7 weeks of age. Now, if you remember nothing else from my talk today, I want you to remember these two sentences. Rapid growth between 1 and 3 months of age of infantile hemangiomas, with an accelerated rapid growth between 5 to 7 weeks of age, because this has a lot to do with the prognosis of this child, if you recognize that. So growth of infantile hemangiomas is usually completed by the time they're 5 months of age, but sometimes it can continue until they're a year old, okay? Involution will start somewhere between 6 and 12 months, and the majority of these will regress, pretty much most of it, by the time they're 4 years of age. And as they involute, they will flatten and shrink and fade in color. So this is just some pictures to show you at baseline, after a few weeks, a few more weeks, a few more weeks, how these things start to flatten and fade away. Even these big things that are raised up, okay? And sometimes they leave a little residual. It's not completely flat. The skin's a little loose. There's a little telangiectatica. That can be corrected later on. But most of the time, it's a pretty good result. The trouble is that although most infantile hemangiomas involute, it may be incomplete and may leave permanent skin changes that could be life-altering for the child. And these are especially true for the infantile hemangiomas that are thick. So you look at this kid's nose, there's a nice thick one here. And as it's involuting, it's changing the structure of the whole nose so that the child's nose will never look right if this goes on. Infantile hemangiomas can be classified by their depth. So they're superficial ones that are red on the surface but have little or no subcutaneous component. There are those that are deep, can be blue or flesh colored, and they're deep below the skin surface. And then there are those that are combined that have both the superficial red area and the deep component to it. So, okay. They can also be classified by their anatomic configuration, as in it's localized or focal, or it's segmental. And segmental are usually larger. They're kind of plaque-like, and they may be associated with extracutaneous signs, which we'll talk about in a minute. Or you may have multifocal infantile hemangiomas, more than one site. If you have more than five or more, you have to think that you could have these in the liver also. It's kind of a marker to tell you, look at the liver, okay? So there's a small set of these hemangiomas that are associated with congenital anomalies. The first is called the Faces Association, PHACES, which is these hemangiomas along with defects of the posterior fossa, the P in the brain. These hemangiomas, which are segmental on the face, scalp, or neck. A for cerebrovascular arterial anomalies. C for cardiovascular anomalies, most commonly coarctation of the aorta. Easy to remember, that's also C. And lastly, eye anomalies, and the S is the association of also sternal clefts with this. So that's Faces syndrome. There's also something called lumbar syndrome, which is lower body infantile hemangiomas and other skin defects, urogenital anomalies and ulceration, myelopathy, bony deformities, anorectal malformations, and renal anomalies. Again, remember that there are two groups here, the facies and the lumbar. One is up in the head, the other is down in the lower body there. Okay, so why did I tell you if you should remember nothing else, you should remember about the rapid growth between 1 and 3 months with that acceleration between 5 and 7 weeks? Is because in the last year or two, we have new data on, and I'm going to quote this from pediatrics, the timing and nature of proliferation and involution, risks of sequela, and newer treatment options. So that early and frequent monitoring in the first few weeks and months of life is absolutely crucial in identifying those children who will require intervention, because these may change rapidly during this time period. So we have a window of opportunity to treat problematic infantile hemangiomas. And if we think they're going to be problematic, then we want to have a consult by the experts by a month of age, because we think there's a potential risk for disfigurement, like that nose or other parts of the body. There may be life-threatening complications, which we'll talk about. There may be functional impairment, we'll talk about. There may be ulceration and underlying abnormalities, and we'll go through all that. So who do we send these people to? We send them to the specialists. There's groups that will have both the pediatric dermatologist, the facial plastic reconstructive surgeon, the pediatric eye doctor, ENT doctor, the pediatric surgeon, the pediatrician, etc. So we send them to Riley, or we send them someplace where they have people who know how to deal with this, okay? So what are the indications for either early treatment or at least sending for an early evaluation? Life-threatening complications, as I said, functional impairment or risk of functional impairment, ulceration or risk of ulceration, evaluation for other structural anomalies, and the risk of leaving permanent scarring or distortion of anatomic landmarks. So what do I mean by life-threatening complications? Well, you can have an airway obstruction from an infantile hemangioma in the airway. These are usually subglottic. The diagnosis is frequently not made until 4 months of age, even though these babies had symptoms before, but it was mistaken because people thought the kid had a little croup, little stridor. Nobody picked it up, okay? The risk of having an airway hemangioma and it causing obstruction is increased if you have hemangiomas on the face in what's called the beard distribution. They're usually segmental in the lower face. So if you see that, you should think this child is at risk for airway hemangioma and possible obstruction, and this kid ought to be sent for an evaluation to the clinic where Peds ENT can take a look and see what's going on there. Okay, so half of the kids who develop airway obstruction from infantile hemangiomas have this skin thing in the beard or anterior neck or oral pharynx that you can see easily ahead of time. Ulceration is the most common complication of infantile hemangiomas, and the risk for ulceration is if they are a large hemangioma or if it's a segmental one, if it's on the head, neck, perioral or perineal or perianal area. These are all areas of risks for ulceration. So there can be a life-threatening complication of profuse bleeding from an ulcerated hemangioma. This is fortunately extremely rare, and we don't have to deal with that very often, but it is a potential problem. Another problem is that's rare is high output congestive heart failure from multifocal hepatic infantile hemangiomas that are asymptomatic usually, causing high flow microvascular shunting, which is why if you have 5 or more obvious hemangiomas on this baby, that you do ultrasound looking at the liver for these hepatic hemangiomas to see if we're going to have trouble with them or not. Okay. Just again showing you the association with multiple ones on the surface with angiomatosis inside, especially in the liver. And sometimes you can actually get a lethal abdominal compartment syndrome from one of these large hepatic hemangiomas type thing. This is pretty rare also. Another thing these hepatic hemangiomas can cause is hypothyroidism, believe it or not, because it causes an excess production of type 3 iodothyronine deiodinase that can cause hypothyroidism in our babies. So lots of things to worry about with hepatic hemangiomas. Now, I did mention to you that kids with face syndrome have a risk of having severe coarctation of the aorta. So you want to send them because of that, not just because of the face syndrome and everything, but to be evaluated for that sort of severe complication also. Okay. Also, existing or imminent functional impairment, either in terms of vision, hearing, or feeding, should cause you to send this child for an intervention to the experts. So visual, you might start with just a little redness, then it starts to raise up and get bigger. Eventually it will cause ptosis, which will go over the pupil, will cause amblyopia, and eventually could lead to loss of vision in the child, and if something isn't done. Same thing with the ear. You could have a hemangioma occluding the auditory canal or even occluding the external ear apparatus. Feeding impairment could be because of hemangiomas on the lip or inside of the digestive system causing obstruction. Segmental hemangiomas are more likely than the others to develop complications, especially ulcerations. And facial hemangiomas are more often complicated than non-facial ones. So indications for intervention: to have this kid evaluated to identify structural anomalies that might be associated with the face syndrome or the lumbar syndrome. to treat for the likelihood that they may have permanent disfiguration later on so that we could prevent this sort of thing, for possibility of getting a nasal deformity, for the high risk of scarring that there is in facial segmental hemangiomas, for segmental hemangiomas on the extremities, if they're large, high risk of ulceration, high risk of permanent skin changes such as thickening, atrophy, or scarring. In the perineal or perianal areas, increased risk of ulceration. So what is our treatment for hemangiomas? Before 2008, we gave them all systemic steroids. Then it was serendipitously found that propranolol works, and the propranolol is now our first-line systemic agent. It is extremely effective. There are contraindications, real asthma, hypotension, heart block, cardiogenic shock, sinus bradycardia, precautions in face syndrome. Because of their intracranial anomalies, you can cause problems, so I would not treat somebody with face syndrome myself. I would send them to the expert and have them evaluated completely before that got treated. So if you're starting to treat these little ones, because they're little ones and they can have complications, you need to start treating them in your clinic with cardiovascular monitoring for at least 2 hours. If the infant's less than 8 weeks old or less than 48 weeks post-conceptual age, you should start treatment as an inpatient. Or if there's for social situation or other increased risk factors, you should start as an inpatient. You start at 1 milligram per kilo per day. You divide this into 2 doses. And you gradually increase to 2 to 3 milligrams per kilo per day. If you are increasing by more than 0.5 milligrams per kilo per day in a young infant, you should monitor them for 2 hours in the clinic for dose increases. Now, the question of how long do you treat, it depends on when you started and the clinical response, but the average is that most kids are treated till about a year of age. And we all know propranolol has side effects, sleep problems, cold hands and feet, diarrhea, and of course bronchial hyperactivity. Fortunately, the side effects of bradycardia, hypotension, or severe hypoglycemia are very, very rare. And in the literature, it has been shown to be extraordinarily rare also, fortunately. But we do want to counsel the family to give the dose of propranolol with or after a feeding so that they can withhold the dose if the child is not taking well PO or is vomiting. This will reduce the risk of the child having hypoglycemia. We also want to tell them that the child may have some sleep disturbances. There is possibility bronchial irritation and the remote possibility that there might be symptomatic bradycardia or hypotension. So just some pictures on kids who have been treated with propranolol. So there may be contraindications like asthma to propranolol, or maybe propranolol failed, so we can go to oral prednisone or prednisolone at 2 to 3 milligrams per kilo per day in a single morning dose. We usually treat them until they're 9 to 12 months old, and then we have to taper them off this gradually. You all know the side effects, so I won't go into that. Sometimes small lesions are treated with intralesional steroid injections. This is to be done only by people who are experts in this, and it's certainly not the first-line treatment. First-line treatment is definitely the propranolol. So if you have some uncomplicated, small, thin, superficial hemangiomas, you can use topical timolol. That's the stuff you use to treat glaucoma. You want to use the timolol, that's the 0.5% gel forming solution, because there's less absorption, and you just put it on where the area is. And this seems to work also quite nice if it's small, thin, superficial hemangioma. Okay, timolol is also beta adrenergic receptor inhibitor, and there are many reports that show that it works and has minimal adverse side effects, mostly local irritation. There were a few patients with bronchospasm, but no cardiovascular events reported. And certainly treating these things early on might inhibit the growth that needs you to go on to more extensive treatment for these things. Some kids do require laser therapy. Again, this is done only by people who are absolutely experts. Lasers can also be used for post-involution, that little residual telangiectasia that I showed you previously. And they usually use the pulse dyed laser because the light's absorbed by hemoglobin, and these things are, of course, full of hemoglobin. And the reason one would want to do it, because some of these, especially these segmental things, can lead easily to ulceration, scarring, and hypopigmentation later on. Surgery is generally not recommended for hemangiomas. There's an increased risk of very poor aesthetic outcome. There can be iatrogenic injury and blood loss. So you want to protect your patients from taking their kids to a surgeon who might know the natural history of this illness and think that they should, cut this off and sew it back up again. The only time I would say you might have some surgery would be a little microsurgery if you have some loose skin that you want to tighten up after this is completely involuted for a little bit better cosmetic outcome. So that's it for today. That's part one of neonatal stuff that you can see on the skin on the outside. And I look forward to part two sometime in a few weeks. And thanks all for listening. And everybody be well. Have a great day.